The benefits institutions to look at this toolkit that we've worked on and try and integrate these perspectives, because not only will it lead to better science, but it will also lead to that science being more likely to be funded.
Being in Belgium, being in Brussels, being with the European Commission in the center, taking all this subject up front is the goal of everybody, and give them tools and skills to spread the word and make people aware.
Hi, everyone. It's really, really lovely to see you here with us today. My name is Rizvi, and I'm going to be your moderator today. I'm one of the founders and the executive director of Youth Cancer Europe. Youth Cancer Europe is a pan-European advocacy network representing young people living with and beyond cancer from over 40 countries. We have been very busy advocating and lobbying for patient rights since our inception and our first AGM in 2017. Here you will see our policy engagement and our EU projects portfolio. You will have seen that we have been very engaged with European policymakers and with parliamentarians, the European Commission, the Cancer Mission Board, and others over the years on things that are priorities for young people with cancer in Europe today. We have also been engaged in various EU projects, amongst which is the European Network of Youth Cancer Survivors, which is a platform for today's webinar. But I wanted to backtrack just a little bit and give you an insight to our work and our advocacy work, and especially our focus on minority populations and equity in Europe. In 2023, we had a year-long consultation with the European Commission that consisted of 4 parts. And in the conclusion, in the Cancer Mission consultation report at the end of this 1 year, it was very specifically noted that young people during these consultations have emphasized the importance of reaching minority groups and disadvantaged populations. And the European Commission promised or committed to enhanced outreach to local communities and further research to better understand the needs of minority and disadvantaged populations. So we think that this is this and many other groups, advocacy work, and a lot of input for European decision makers and grant givers such as the European Commission and the EU Beating Cancer Plan implementation has really contributed to us being able to talk about inequalities today, and more projects being funded for this. So Youth Cancer Europe has been involved in high impact equity, diversity, and inclusion events and policy dialogues throughout 23 and 24 and this year as well. Here is just a sampling of the kind of work that we have done. We had a meeting with the local city hall and decision makers, as well as local stakeholders, university, and the Oncology Institute in Cluj-Napoca, Romania. We had a policy event in the European Parliament with MEPs supporting the work that we have done. A national level policy engagement in the Lithuanian Parliament together with the POLA organization in Lithuania. Again, back in Transylvania, where we had 3 training events for healthcare providers, for researchers, academics, and for patient community leaders. And again, we had last summer a very large event with participants from 34 European countries, with young people in the audience, talking about equity, diversity, and inclusion in patient communities. We did a very similar one just for Romanian young people living with and beyond cancer in Romania and Timișoara at the end of last year. And this year, February or last month took us to the Parliament of the Moldovan Republic, where we were able to speak about not only Moldova's accession to the EU and their new cancer plan, but some of the EDI, equity, diversity, and inclusion priorities that we have identified and the recommendations that we have published recently. I believe that the link to this and many other things that we're mentioning today is going to be dropped in the chat here on Zoom today. And if you have any questions, please do go to the Q&A session or the chat, and we will be taking questions later on. In this recommendation, we are focusing on 4 important areas such as race, ethnicity, culture, refugee or migrant status in young people with cancer, also on gender identity and sexual orientation, on age, physical and mental development and well-being, as well as education, career, and socioeconomic status. And today's webinar is going to be addressing this last point. And within these recommendations, we also have addressed the European Commission. We asked for dedicated funding and resources for research, for programs, and for interventions targeting disparities in cancer prevention, diagnosis, treatment, and survivorship. And we're going to be talking about all of these areas in one way or another today, because of our amazing speakers that we have lined up for you today. We have also asked to expand the scope of social determinants included in the Inequalities Register. And again, our speakers are going to be speaking about the Inequalities Register here today. And we asked for EDI-focused policies, guidelines, and best practices across all member states to ensure equitable access to quality cancer care, irrespective of socioeconomic status, ethnicity, gender identity, sexual orientation, or age. So our wonderful speakers today, Dr. Caroline Burchett, Dr. Salvatore Vaccarella, Andrea Manzano, Georgiana Sabo, and Fleur Bradik is going to join us today. But before we get into their presentations that are going to be so full of little gems and data information for us to learn from, I wanted to quickly outline the structure of today's webinar. So we will be talking about socioeconomic drivers of inequality in cancer care. And then we will look at how we are mapping these inequalities across Europe, and then look a little bit deeper into how inequalities are mapped within different member states. And then we will be looking at case examples. And these stories and examples will take us to the southwest area of Romania and the Catalonia region of Spain. And then we will be talking about health literacy in cancer care and some take-home messages. So we were very excited to have so many people register for this webinar. We were very impressed to have more than 200 registrations. And it was very interesting to see that as the number of registration grew, we still had sort of 50-50 share of participants with lived experience and without lived experience. So that's something that you see on one of the pie charts here. And we also wanted to know about the profession and the background of people who will be listening. And according to this chart, we see that academics and researchers, as well as healthcare professionals, showed the biggest interest in this webinar. Very clearly afterwards, patient advocacy representatives have registered, and curious people who just wanted to be here because they wanted to learn, and that was actually really wonderful to see. And we also have policymakers and public health specialists in the room. You might be hearing us refer to S or low SES, or low SES or SES populations. That stands for low socioeconomic status. You might hear US populations or UR populations, underserved or underrepresented populations. Here is the legend for some of the abbreviations for projects and for organizations such as YCE, Youth Cancer Europe, or OECD, Organization for Economic Cooperation and Development, or YARC, or IHE, and the foundation that Fleur is representing. So these are some of the abbreviations for today. And then I'm very, very pleased to give the word to Dr. Caroline Burchett. She is a health economist at the Organization for Economic Cooperation and Development, the OECD Health Division, working on data analysis and health system performance assessment framework. And on the policy side, Caroline manages the OECD's work on cancer care. She contributes to the European Cancer Inequalities Registry, and we are very much looking forward to hear about that from her, focusing on how diverse data sets help uncover the root causes of disparities in cancer burden and outcomes across socioeconomic groups, genders, and countries. So, Caroline, the floor is yours.
Thanks for the invitation. I'm very pleased to present you the European Cancer Inequalities Registry and some of the key findings on the drivers of inequality in cancer care in EU countries. Next slide, please. So let me just give you some background information on the European Cancer Inequality Registry. So this is part of the Europe's Beating Cancer Plan. It's one of the 10 flagship initiatives. So it's led by the European Commission. So the OECD is part of the project, but the Joint Research Center and IARC are also contributed. So the registry aims to identify cancer burden and trends in cancer care in the EU, to showcase disparities and highlight inequalities both between countries in the EU, but also within countries by population groups, such as gender, socioeconomic status, and migration status when it's available. Of course, the production of the European Cancer Inequalities Registry implies strong and continuous collaboration with other partners and stakeholders to be updated on ongoing initiatives. So just to mention a few, we recently collaborated with the European Society for Pediatric Oncology and also with the European Oncology Nursing Society, only to mention a few. So as part of this collaboration, we recently released the 2025 country profile series. So this includes 29 cancer profiles to provide a wealth of data, policy discussion, and qualitative analysis across the cancer spectrum in EU member states, Iceland, and Norway. So it's publicly available on the European Commission website and on the OECD website. We also produced this year a synthesis report highlighting findings from the profiles. And these publications are also complemented by a new cancer performance tracker for each country to assess the performance of country across several cancer domains like prevention, early detection, care capacity, and outcomes. So it compared country both with EU average, but it also shows the evolution of performance over time. Next slide, please. So to produce this, all this work, all these reports, we use a number of different data sources, of course. Here you can just see some example, but it includes everything from Equis to provide some estimation on cancer incidence. We also used Eurostat and OECD health statistics for things such as cancer mortality or the supply of radiotherapy equipment. We also work closely with IARC that provided some data on inequalities in cancer mortality by education level. And this was also complemented by extensive desk research and also some policy surveys that we conducted at the OECD in 2023 and 2024. And in addition to have and to provide qualitative input in each country report, we also conducted a lot of interviews with experts in oncology, in public health, in epidemiology. So this helped to dive into country-specific issues and to look at national development. Next slide, please. So all this work shows that the burden of cancer in Europe is growing, but it's also marked with concerning trends and substantial inequalities, both between countries and within countries. Next slide, please. So ECI's estimation shows that in 2022, it's estimated that 2.7 million cancer cases were diagnosed in the EU, the equivalent of 5 new cases per minute. And as you can see in the graph, about half of cancer incidence is driven by 4 main cancer types, as you know, so colorectal, lung, prostate, and breast. The estimations show also that the burden of cancer will grow. So by 2040, new cancer diagnoses will increase by around 18% in the EU 27 compared to 2022. So the burden will clearly grow over time, and this will have large impact for health system, for the economy and society more broadly. Next slide, please. In our report, we see that there are some good progress. So we can see that cancer mortality rates fell in nearly all EU countries, Norway and Iceland, as shown in the graph. So the cancer mortality rates fell by 12% on average in the EU from 2011 to 2021. And so you can see high drops in Luxembourg, Malta, and Belgium. We can see that the cancer mortality rates fell much faster among men over the decades through 2021, as indicated in the small white square. Next slide, please. But there are large differences in cancer mortality across countries and within countries, as mentioned previously. So if you look at the left graph, we can see the disparities across countries. So for example, among men, we can see that the mortality rates in Latvia is almost twice as high as in Sweden. And then if you look at the right chart, we can see that there are large differences in mortality by socioeconomic status in EU countries. So we see higher mortality rates reported among more disadvantaged population. So for example, those with low education, as shown in the graph. But during the next presentation, Salvatore will present this work. Next slide, please. So the gaps in mortality that we can observe across countries and within country partly reflect differences in prevalence of cancer risk factor, as well as differences in access to early detection and screening programs, and also to differences in quality care. So we'll see that in the remaining slides of my presentation. So here in this slide, we can see that there are some differences in the prevalence of cancer risk factor by population groups. So the prevalence of smoking, alcohol consumption, overweight, air pollution, but also HPV vaccination, it's not shown here. But the prevalence is consistently higher among the low education compared to the high education groups. So this is a first important explanatory factor. Then if we look at differences across countries, it's important to mention that cancer risk factor is also much higher in some countries, notably in Eastern and Central European countries. So for example, on smoking prevalence, the rates range from a low of 6% in Iceland to a high of nearly 30% in Bulgaria. So clearly, this disparity in the prevalence of cancer risk factor explains the inequalities that we can see. So in our work, we show that across the board, there remain great opportunity to reduce the cancer burden and related inequalities by making concerted effort on a range of risk factors. And this is shown in the right chart. So our OECD modeling study shows that almost 1.9 million new cancer cases could be prevented in the EU if tobacco reduction targets were met. Yet, you know that spending on prevention continue to be only a small part of health budgets. So in 2022, only 5% were spent on prevention. So this is very low. Next slide, please. We also show in our report that trends in screening rates are very concerning. So there are two important findings here that I want to mention. The first one is that countries are generally struggling on participation rates across the three main programs, so breast, cervical, and colorectal cancer screening programs. So as you can see in the graph, you have the EU average, but also the highest participation rates and the lowest participation rates. So on average, at EU level, the screening rate stood at 55%, 56% for breast and cervical cancer, and 42% for colorectal cancer screening programs. And again, we can see large inequalities across countries. It's not shown in the graph, but European Health Interview Survey show large inequality by education level and also by income level. What is really concerning is, which is my second point, is that you can see in the majority of EU countries that the participation rates are declining over the last decades. And this is true for the three main screening programs. So this is shown in the second part of the slide. So you can see, for example, that between 2014 and 2022, breast cancer screening rates fell in nearly 60% of countries. And these declines were already evident in 2019, before the outbreak of COVID-19 pandemic. And a similar trend is observed for colorectal cancer screening. It has been declining in 56% of countries, and cervical cancer screening program participation rates have fell in 65% of countries. So this is huge decline. So countries need to improve the health literacy of people and to reach the most vulnerable population to improve participation rates. Next slide, please. To end with the presentation, let's have a quick look at the resources available for cancer care. So here in the slide, we see that the workforce and access to therapy for cancer care vary by up to sixfold across EU countries, so depending on the indicators, obviously. And this, again, explains some inequalities that we can see in cancer outcome across countries and within countries. So if you look at the left graph, it shows the density of medical, radiation, and clinical oncologists in the country where data is available. We can see that the highest density is found in Italy, but also in Czechia. So we have more than 7 oncologists per 100,000 population. And the lowest is found in Bulgaria, but also in Malta, with 2 or fewer oncologists per 100,000 population. So this is a 5-fold variation. So this is large, and it can create some barrier to access to cancer care in countries with the lowest supply of oncologists. We can have the same conclusion if you look at radiotherapy equipment. Our work shows that over time, radiotherapy equipment, the supply has increased over the last decade. So this is a good thing. But at the same time, we can see that there are large disparities across countries. So we can see an almost a more than 2-fold variation across countries. So for example, between Slovak Republic and Portugal. And there are also clear room for improvement if we look at reimbursement of cancer biosimilar and also on access to essential medicines for treatment of pediatric cancer. So again, you can see large variation across countries. Next slide, please. So I invite all of you to consult the cancer profile of your country. You will see it provides rich evidence on the performance in cancer care system, from prevention to the quality of life for people living with cancer. But meantime, don't hesitate to contact me by email to ask any question on the registry or the key findings. Thanks a lot.
Thank you as well, Caroline. You've been so helpful, and we really appreciate you taking your time to explain to us about the EU Inequalities Registry and the data that you have already coming in. And I believe that in the chat, our audience will find the appropriate links to looking up these reports and this work. And some things that really stood out to me that I know that we will be discussing later as well is education level and simple things as access to fresh vegetable or fruit, and how socioeconomic status, education level, and all these other social determinants, as well as the community and the area and the region where you live, really affect maybe your chances of, your access to screening, understanding prevention messages, getting right access to care. And we're going to continue in this vein with the upcoming presenters. Thank you, Caroline. I know that you have limited time for being here, but if you can, please join the discussion later on. Thank you so much. And our next presenter is going to be Dr. Salvatore Vaccarella, who is the coordinator of the Cancer Inequalities team in the International Agency for Research on Cancer, IARC. And you have heard Caroline referring to their work and to Salvatore's work as well. Salvatore is researching social and gender inequalities in cancer, in health system inefficiencies, very interesting topic, over and under treatment, focusing on innovative epidemiological methods to understand these issues and inform public health policies. Dr. Vaccarella also leads the EU Can INEC project, but I think you will pronounce it better. It's a mouthful of an acronym. It's looking at cancer inequalities in EU regions with a socioeconomic focus. And this project will end in July this year. So we are really looking forward to understanding what we can learn from you. And you're also developing research and data frameworks to study socioeconomic inequalities in cancer for the Inequalities Registry. So the floor is yours, and I believe you will be sharing your slides.
Yes, thank you very much. Good afternoon to everyone. It's a pleasure for me to be here. I guess I try to share the slides. Can you see them? Okay, very good. So I will discuss in the next 10 minutes our project.
I don't
And
know if we can see your slide just yet.
can
Am I
you?
the only one who doesn't see your slide?
You cannot see them.
Everybody can see your slide. Everything is good.
Oh, okay.
Okay, fantastic. So, okay, so as I was saying, I will discuss about the socioeconomic inequalities in cancer across Europe, in particular in cancer mortality, and in particular our project, the EU Can INEC, who is a EU Commission project, and it is in collaboration with the other components of the European Cancer Inequality Registry. We've seen OECD, Caroline just before, DG Santen, the GRC, and us, the International Agency for Research on Cancer, IARC. So we go with the first slide. Let me see if I can change it. Okay, very good. So this topic, socioeconomic inequalities and cancer, has been somehow overlooked for a long time. Until 10 or 20 years ago, there was not much discussion and research about that. But fortunately, in the recent past, there has been a revived interest on that. And fortunately, also at the European Union level. Oh, so despite the many studies on the topic, but there is still a lot of gaps in the data, in particular data that could monitor and compare benchmark different countries in Europe. So there is not enough sufficient data that could map this problematic. But when the data that are coming out, they point to the fact that socioeconomic factors are possibly the most important factor explaining the distribution of cancer between and within countries. Socioeconomic factors and socioeconomic inequalities, they affect all stages of the cancer continuum from the distribution to the risk factors up to access and use of effective treatments. And so in this project, we focus mainly on mortality because mortality is the ultimate indicator of health in general and of cancer, of course. And identifying inequalities, socioeconomic inequalities in cancer mortalities is like the sum, it gives us an idea of the sum of all the inequalities that occur across the cancer continuum. So this is the map of euros. You can see on the left we have cancer incidence, on the right cancer mortalities. For now we focus on socioeconomic inequalities between countries. There is no the socioeconomic axis in this moment, but you can see that for cancer incidence, the panel on the left side, incidence is much higher in countries in the north and west of Europe, which usually are also the countries that are more developed according to at least certain parameters, educational level, income, and so on. And however, despite and for Eastern European countries, the incidence of cancer is relatively lower. But despite that, as you can see from the panel in the right, mortality rates are higher or much higher than those observed in northern countries or Western countries. So already we can start to see this kind of socioeconomic axis and the East-West divide that has been mentioned in the recent past in many projects. So this is already pointing towards some inequalities between countries. Let me go a little bit further. If we put this into a correlation analysis, we can see that as the socioeconomic development of the countries increases, cancer incidence increases, and this has been mentioned also before by Dr. Berger. But mortality somehow has a different correlation with socioeconomic development. Countries that are less developed, they still have a very high higher mortality despite the relatively low incidence. So this is the map that where our work starts. But we want to go with our project, the EU can enact. We want to go one step further and see within each country who is paying the highest price for this, especially for mortality. No? We see that most of the differences are between the East and the West are down to the Eastern European countries, but what happens inside each of the countries? That is the goal of our project, EU can enact. The result will be, we have already produced some of the results for some countries, for 16 countries. And very soon we will have also the final results and we will be able to benchmark all the 27 EU countries plus Norway and Iceland. We already said this is within the European Cancer Inequality Registry initiative. And let me go to the next slide. Specifically, our project focuses on the socioeconomic axis. We said before that this is a crucial factor explaining the distribution of cancer within countries. And our project is based on a bulk of very important data that are observed data in certain that are available only for certain countries, for 16 countries, and for several periods of time. And also another part of the project involves the extrapolation and the development of some methods to fill the temporal and geographical gaps. Also, we benefit from the IAC experience into cancer and cancer inequality to explain, to interpret these inequalities that we observe. So the core of the data, the most important data, observed data that we have, they are called ERINE, and they are coordinated by the Erasmus MC, particularly by Dr. Wilma Nasselder. And this has been a very important collection of data, of observed data on cancer mortality for different cancer types, the cancer mortality by education level and by age and sex. So as mentioned, we have already data for 16 countries for different periods. You can see the panel on the right side. And the collection of this data is quite important because it involves quite a logistical process, and because it involves the interaction with each national provider, which links the individual level data on mortality with the education level data from the census or the registered data. And then all these data are harmonized, which is quite a complex process, but it allows to benchmark countries, to compare countries. This is very important. Another important thing is that for most of the countries, the population coverage is 100%. And this is particularly important when we talk about socioeconomic inequalities, because most of the observational studies and other studies, they have the tendency to exclude the lowest part, the most disadvantaged population. So it's important to have a very strong coverage. So we said we have 16 countries with observed data, and this is somehow a summary of the methodology to estimate cancer mortality by education for the target period, which is 2015-2018. For some countries, we have indeed the actual data, and for other countries, we need to do small projections or we need to overcome some small gaps in the period. And this is somehow the summary of the method that we used. Then what is interesting is also what do we do with the other 13 countries where we do not observe data. So for this, we use still several databases. One is still we borrow information from the ERINE data, the one that we shown before, according to the geographical area. But also we use other important and large and high quality databases like the WHO mortality database, Eurostat, and several of the IARC global databases. And for these countries, we develop a methodology which is called back calculation approach, where we can manage to fill the geographical gaps and therefore to obtain estimates also for these countries. We always need to say that having observed data is much better than having have to estimate and making some projection or some extrapolation. So ours is also, we will always would like to incentive the production of data, although it is becoming more and more challenging to do so. But having the observed data is the most important thing to monitor inequalities in cancer. So these are some of the results. These are just a sample of the results. For the moment, it includes only some of the countries with observed data. We already published this in a previous report, but you can see on the panel in the center, you can see total cancer mortality in men, and we can see massive inequalities, massive differences between people with low education level versus those with high education level. In every country, there are major inequalities. In some countries, these inequalities are larger. You can see Eastern Europe in particular, and we go back to the initial map where we've seen high rates of cancer mortality in Eastern Europe. But in fact, this cancer mortality really is somehow clustered among the most disadvantaged in those countries. So it's important to know which segment of the population are more affected by cancer. I do not show women here, but it's also interesting the situation in women because in addition to Eastern European countries, inequality is very large also in the Nordic countries, which is somehow a paradox, quite unexpected. And this is due to the to the to the increase in lung cancer, inequalities in lung cancer among women. Another cancer that affects women is cervical cancer. This is a cancer that could be virtually completely prevented through vaccination or screening, but still we see a lot of inequalities. You can see the map there. Yeah, in this presentation, there is no time to go through all the data, of course, but I invite you to visit our website and previous report. This is the timeline of the project. The most important thing that I would like to say is that in 1 month, on the 23rd of May, we will have the presentation, the launch of the country-specific fact sheet. So we will have all the 27 plus 2 countries. So in that day, we will launch all the statistics and the indicators, and hopefully you will be participating to that meeting event. It will be online. And yeah, I have some conclusion. I think I'm still in time. So the main point of this data is that the burden of cancer is not equally distributed. And socioeconomic condition is really the most important, arguably the most important factor discriminating between, on the distribution of cancer between and within countries. These inequalities, socioeconomic inequalities, are very large. They exist in every country and for most cancer types. So really are ubiquitous. The most disadvantaged pay the highest price. We always need to keep in mind this from the research point of view, but clinical point of view as well, and from the health policy, public health policy point of view as well. Something I haven't mentioned, but is that we see from the data is that the most educated men and women or affluent, somehow they have lower rates almost everywhere. So it seems that somehow they can protect themselves. This is quite interesting. For the disadvantage, however, is really important the place where they live and the way the health system is organized. In some health system can manage to cover them somehow to reach them and so reduce the inequalities. Whereas in other health systems, inequality is very high and the burden of cancer among disadvantage is very high. Approaches that are one size fits all, one single message, they have the tendency to fail to reduce inequalities because these messages are received and digested in a different way across people, across different social groups. And the last message that we always try to emphasize is that any intervention or cancer control measure should be explicitly designed to reduce socioeconomic inequalities or at least not to increase them. So my presentation is finished, but if you have any question, I will be very happy to try to answer. Thank you very much.
Thank you as well, Salvatore. Some of the things that you're mentioning really stand out. Obviously, actually, it's still on the shared screen right now. You're saying that affluent individuals know how to protect themselves. And we've also seen in Caroline's presentation that there is a very strong correlation with a better educational status and cancer mortality or even cancer incidence. And that's, and we will be talking about this later on in our panel with Fleur, who have done a lot of work in prevention, that obviously once you do have cancer, it's very important that we don't blame or shame anyone. Like, okay, this could have been preventable because of unhealthy lifestyle, food intake, vegetable intake, exercise, tobacco exposure, or use, or air pollution exposure, etc., etc. So this is very, very important to specify that we all need to take responsibility and accountability for this. We're not going to be blaming the patient. But what stands out to me is that you're saying that interventions should be explicitly designed to reduce socioeconomic inequalities and not to increase. Do you know interventions that actually increase socioeconomic inequalities?
Somehow they might, because several interventions might increase inequalities, because if you have a one-size-fits-all message, for instance, go to do screening, or don't smoke, or eat well. So this message is received in a different way from people. So and it's left, like you said, is left up to the individuals to make a choice. But we know very well that the environment influence individuals' behavior. So it is important that these interventions are really specifically made to target everyone, and particularly with a stronger effort, those that are likely to be affected the most. Um, so I think intervention might have the possibility, many interventions, to increase inequalities instead of decreasing them if they are not specifically designed for that. So I think we always like to emphasize that it would be nice that this and this kind of framework of thinking mindset would be always in our mind, when we do research, or when we plan some intervention and so on. So.
Thank you. Thank you so much. And we will be speaking about this later on. So everyone, please stay online and keep being tuned in. Thank you so much, Dr. Vaccarella, for your presentation. And we're going to move on to hear more about some details like vaccination uptake, and education and socioeconomic status from Andrea Manzano. Andrea Manzano is a health economist at the Swedish Institute for Health Economics, specializing in the economic burden of cancer and its broader social impact beyond healthcare costs, which is also a very important thing that we will be looking at. She has co-authored reports on cancer care in Europe and in the Middle East, with a focus on disparities in access to care across socioeconomic and ethnic groups. She will present key findings from the report Tackling Inequalities in Cancer Care in the European Union, which explores inequalities by socioeconomic status, geography, sex, age, and looking at health literacy and rural-urban divides and more. And I think the previous two presenters were a very good precursor and set the foundation for you, Andrea. So we're looking forward to yours. The floor is yours now.
Thank you very much for that introduction, Kari. I'm gonna share my screen. So if there's an issue, please just let me know.
You're good. We see you.
Excellent. Thank you very much. Excellent. So I'm very honored to be here with you today, sharing some findings of a report from IHE. As Kati already explained very kindly, I work in the Swedish Institute for Health Economics, and I work in the cancer policy team. And in my team, we several times need to understand what are the most important challenges that patients face in their whole cancer journey. So since prevention to detection, diagnostics, treatment, and survivorship. And we find the same story again and again, where someone lives, how much they earn, the level of education they have, has an impact and shapes the entire cancer journey of patients. So today I'll share the findings of a report that my colleagues Andreas Pusset and Thomas Hofmarcher wrote. It's called Tackling Inequalities in Cancer Care in the European Union. And they look at between countries inequalities, but already Dr. Salvatore, Dr. Averchet have already touched upon those. So I will talk about within countries inequalities. For instance, level of health literacy, or the differences that geographic distance to university hospitals or comprehensive cancer centers create in cancer outcomes. So in this report, and I think you'll get the link for that report, there are 5 case studies. The first one was access to HPV vaccination. The second one, access to colorectal cancer screening. The third one, access to simple and multiple biomarker testing. The fourth one, access to cancer medicines. And the fifth one, access to financial support. And for timing issues, I'm only going to talk about the first two, HPV vaccinations and colorectal cancer screening. But I can already tell you that age, socioeconomic status, and urbanization level are the dimensions with the highest level of inequality across the case studies. And there was also this cross-cutting theme about health literacy. So individual aspects to health literacy, such as the knowledge that patients have, the perceived risks of disease, all have a huge impact in each of these case studies. So HPV vaccination is a cornerstone of cancer prevention to prevent cervical cancer, but also other HPV-related cancers. My colleagues found that there are many inequalities within countries. The first one is related to sex. The inclusion of boys to national vaccination programs has been more gradual. It started in 2006, 2007, national vaccination programs for girls. But for men or gender-neutral vaccination programs started in 2014 in Austria. So it has been more gradual. The town vaccination coverage rates are also more patchy for boys than for girls. As a second dimension, there's the education level. Studies in Northern Europe indicate that there is a strong correlation between the education level of parents, in particular mothers, and HPV vaccination uptake in girls. And third one, families in low socioeconomic status have lower HPV vaccination uptake based on several systematic literature reviews in Europe. So this pattern shows how being poor or being socially marginalized means many times missing out on HPV protection. But now the question is, why? Well, the reasons behind these inequalities have multiple factors. For instance, low-income families that live far away from healthcare points can have additional barriers like hidden costs, transportation costs, or they may need to take time off work. Another dimension is health literacy. So parents that have less knowledge about HPV vaccination and that understand less about the risks of not getting the vaccination are less likely to consent. In other cases, fearing the vaccine side effects can reduce also vaccination uptake for certain groups. So ensuring equal access requires both lowering practical barriers, but also increasing trust. And now I'll move on to the second example for colorectal cancer screening. And the screening methods for colorectal cancer screening can vary, but most countries have or adhere to the EU Council recommendations, where a stool sample test is done first, and then if there are abnormalities, a colonoscopy is recommended. So my colleagues found that there are many inequalities within countries. The first one is related to sex. Men participate less in colorectal cancer screening than women. And as we can see in the graph here, the countries that have the biggest gaps are Latvia, Lithuania, and Germany. Second, age. Individuals that are at the lower end of the target age that tends to be 50 to 79. So the ones that are in the 50s get lower colorectal cancer screening rates than the patients that are, or the people that are in their 70s. As a third factor, income. People with low income were less likely to get screened, even if there was a national program available. Also, there are individuals with, also education is very important. Individuals with tertiary education tend to participate more than those that have lower education levels. As well as urbanization level plays a role. A longer distance is associated with both lower test participation and also longer time to do a follow-up colonoscopy. And there are, of course, other vulnerable groups like migrants, like ethnic minorities. that have also lower participation rates. So again, the reasons for these inequalities are multifactorial. There are, of course, logistical barriers. Like screening, as I said, involves multiple steps. It involves getting an invitation if there's a national program, doing a stool test at home, then sending the stool test back. And then if something abnormal happens, you need to undergo a colonoscopy. So in each of these steps, there are chances of getting lost in the system and not having an easy way to go to the healthcare center, to go and pick up the sample test. All of these are barriers that hit more underserved populations. There's also something interesting that individuals with poorer self-perceived health that are obese or that smoke or that have sedentary lifestyles are less likely to participate in screening. So it is an irony that people that are at a higher risk of getting colorectal cancer screening get less or go less to screening. And my colleagues gave some high-level recommendations in this report. They divided into long-term recommendations and short-term recommendations. For instance, for long-term recommendations, they added improved personal and organizational health literacy that we know is very important for cancer patients and the public in general, and ensure education and continuous training of medical staff. They also included short-term recommendations, like introducing a free of charge gender-neutral HPV vaccination program and consider a school-based system for its implementation. Also for improving participation to colorectal cancer screening, they wrote that it's very important to make the easy choice, the right choice, the easy choice. So make participation as easy as possible, for instance, by sending and collecting test kits by post. But I wanted to end up my presentation with practical examples of what each of us can do to reduce cancer inequalities. So I think that patient advocacy groups and journalists can highlight testimonies from patients in rural areas that live in low-income neighborhoods or minority ethnic groups and talk about their journeys, and then use their stories to feed discussions. Also, healthcare professionals, what can you do if you are a healthcare professional? Well, you can proactively recommend screening and vaccination to eligible patients during routine visits, but especially to those who might not ask for it, just as men, migrants, or low-income patients. And what can you do if you're just a curious participant? Well, you can encourage conversations that normalize prevention, like talking about how you got screening or how you got vaccinated. And with this, I end up my presentation. That's the QR code for the report. Thank you very much.
Thank you so much, Andrea. And we have also dropped the links in the conversation below. And I'm so happy that you pointed out some of these things. And there was something very interesting that you said, that individuals with poorer self-perceived health are less likely to participate in screening. I would like you to think about this because I will ask you why it is. So stay with us. We will have a little conversation about this and about health literacy in general later on. But I really think that right now it's time for us to actually look at what's happening on the ground level. You gave some good recommendations, Andrea. Thank you so much for being with us. And let's see how these recommendations actually might play out in the real world setting. I'm very, very, very pleased to welcome to this webinar Georgiana Sabel and Fleur Braddick. Georgiana is a primary school teacher in Drageš, the Bihor, working with Roma children, focusing on promoting inclusive and equitable education. She is also actively involved in community development through her role as vice president of Asociația de Tineret ELF in Oradea and as a volunteer with the Romanian Red Cross. Our paths have crossed before as we worked together, as she was also volunteering and helping us. If you could please go back with the presentation to the slide with our panelists. Thank you. And also I would like to welcome Fleur, who is a human scientist and medical anthropologist specializing in public health research, project coordination, and science communication. For over 20 years, she has contributed to European projects on mental health promotion and disease prevention, addiction research and capacity building, alcohol harm reduction, co-creation and implementation research. She currently works on the project HD. We will hear about this more. And the project aims to reduce cancer risk among specific disadvantaged populations. And very specifically, we will talk about some strategies about to be deployed in the Catalonia region and communities. And she also has done previous works and workshops in another project, Deep Seas, developing and extending evidence and practice a standard European alcohol survey project. And this is focusing on multi-sectoral approaches to reduce alcohol harm, with particular attention to its links to cancer, socioeconomic inequalities, and nutrition and obesity. We are covering quite a wide area, and I'm so happy that you come with such real specific experience that you will be sharing with us. I think we can, yes, thank you so much. I think we can start with Georgiana. So we listened to all the effort the EU is putting into focusing on inequalities, the inequalities register that was explained by Dr. Berger, and how difficult it is to pull some of the data and some of the projects to pull this data from Dr. Vaccarella. And we also looked at some of the reports and more granular understanding of health literacy affecting uptake of screening in different scenarios from Andrea. So how does this actually play out in real life? Georgiana, I'm going to first come to you. You've been working with Roma communities, and you also have a background working with the Romanian Red Cross and healthcare. I know that you have been involved in negotiating some or advising communities for better healthcare access. Tell me about your experience.
Yes, it's true, and it does affect them very much. For example, we have a case that basically because of the lack of education, basically they went. So she was feeling sick. She came to school one day, and I called her parents, and they decided to take her to the hospital. After she had the surgery, and the doctor was trying to tell the parents that they should go with the child to Timișoara because she might have a very serious problem. But they understood, or they basically misunderstood what the doctor wanted to say. So they took her home on the sign of the paper. And a few days later, when they went to the doctor, like the family doctor, he told them that they have to go like very urgent to Timișoara because the child might have a very serious.
The regional hospital, the center, right?
Yes, yes, but they said she could have some kind of very serious form of cancer, but nobody told them the word cancer before, so they could be more aware of what the problem actually was, because the word tumor for them wasn't too clear.
Wow. So the doctor ticked the boxes by saying tumor or a mess, but
Exactly.
they didn't use the word that actually the family would have understood.
Exactly. So this led to the, unfortunately, the disease of the girl. This was a medical tragedy and a failure of communication and understanding among the community.
Fleur, may I ask you about the work that you do? So, if you could give us a little insight to the strategies that that you are about to deploy in the neighborhoods, in these very specifically identified neighborhoods in Catalonia, and how did you identify them? And maybe a little bit of context. Maybe we can reflect on what Georgiana also shared.
Thanks. Yeah, so thank you first of all for inviting me to be a panelist on this. I'm really honored to share a forum with all these speakers. And it's really interesting to me that Georgiana just mentioned communication from a medical professional, because this is one very central part of our project, Peached, which is an EU-funded project. And I mean, I'm not going to go into great detail about what it is because I don't want to take too much time.
The
But
link we put in the chat so that people can look it up and
perfect.
find it for themselves. Yes.
Thank you. So, but basically, it's a primary prevention project. So the aim of Peached is to address lifestyle behaviors that increase cancer risk and other NCDs. So the six behaviors that we're trying to tackle are smoking, secondhand smoke, alcohol use, physical inactivity, unhealthy diet, and sun exposure. And we are basing our methodology on a WHO manual, which was a project called Brief, developed by WHO Europe. And the central component of this program that we are developing, well, there are two central components. One is a digital health tool, an app, which will help people to assess their lifestyle behaviors in terms of risk, cancer risk. And the app that we are using and adapting is called Prevican. And the other component is something called brief intervention, which is basically where a professional, traditionally a health professional, has a brief conversation with someone about these risk factors, about these healthy lifestyles and risky lifestyles. So in that element, you can imagine the communication is an absolutely crucial key. And what we're trying to do in Peached is we're trying to train up professionals in 3 different countries. So in Czech Republic, Poland, and Catalonia, which is a regional autonomous region of Spain. And in Poland and Czech Republic, this is being focused towards Ukrainian refugees and diaspora. In Catalonia, as you mentioned, Katie, it's the focus is on lower SES neighborhoods. So we have Catalonia has a socioeconomic index, or it's actually it's a socioeconomic index based. It's a weighted index that's made up of a combination of indices on census data, and through that they've identified I think it's 7 different health areas, so dealt with by the same medical center, which have which are populations living in low socioeconomic status. So one of the critical things about this conversation is that medical professionals often feel much more comfortable talking to someone of the same socioeconomic status as themselves. Mm-hmm. So it can be quite challenging to bring up behaviors that people can feel judged by: alcohol, tobacco, whether you're eating healthily, how often you exercise, and so on. So one of the things we're doing in Peached is training sessions for professionals which use a motivational interviewing approach. This is a very respectful and inclusive approach to offering medical or health advice. And the main sort of justification for looking at low SES is that, as we heard from Salvador Vaccarella and from Caroline Bechet, that the inequalities, there are inequalities in cancer. There are also inequalities in the incidence of NCDs. The mortality is even more exaggerated, the inequalities. And the main of interest to us in the prevention field is the behaviors that, the risky behaviors also lie on inequalities, but these do not associate linearly with the harms that we're seeing. So there's a paradox in how the risk factors can be, how the risk factors can, sorry, my family's coming home, how the risk factors can be translate into the harm that we see. So this is most famous with, for example, the alcohol harm paradox that some of you may have heard of, which is the phenomenon that there are higher rates of harm in lower SES groups, despite having similar or lower levels of drinking. So there's some problem upstream which is causing these people not to benefit from the lower risk that they're taking. And we can see this also in diet, in that in some ways meat is expensive, so people will not necessarily buy it if they're living with less resources, less financial resources, but they may have, for example, greater density of fast food outlets in their neighborhoods, which is another risk factor for cancer.
The context really matters.
Context really matters. So this is, thank you, you summarized it well. So we're interested in these social determinants, and to summarize what this means for us in practice or in practical terms, it means we have to be very careful with what recommendations we give, because as Salvatore already said, we can give recommendations, but if they're received only by those with higher education and higher resources, if we say you should take you should do 30 minutes of high intensity physical exercise a day, we can translate these into something that seems practical to us. For example, you can get off the bus 2 stops earlier and walk. But if someone lives on the other side of a motorway or in a place that's not suitable for walking, we're not actually giving them any actionable recommendations. So the main sort of message we try and give, or how we have to be careful, is to target and tailor our recommendations towards disadvantaged groups. So this is, as you said, about the communication. The second one I'd say, and I'll try to be very brief.
Yes, maybe, I don't know if you don't mind, I would like to bring it back to Georgiana, just so that we don't run out of time, but thank you. You have shared so much already, and this has been really, really helpful. And I think what I would like to bring back to Georgiana, I don't know if you have any other case examples, or you can just reflect on some of the things that Fleur has shared. And there was a wealth of information that you have shared with us, Fleur. And you talked about the accountability of the system. So that you said that, maybe some people in higher risk groups put themselves at less risk than others in the general population and still have worse outcomes. Because, in one word, the system is failing them. Yes, Georgiana, can you tell us a little bit more about your work?
Yes, actually, I have a pretty great example. For example, my children, they always bring to school chips and tea. and sodas and things that are buying from the supermarket in the morning. And I always call the parents and tell them, please wake up a little bit earlier, pack them something from home and bring them to school, so they don't have to eat lots of sugars in the morning and have a lot of energy. They are always trying to tell me that, yeah, we will try to wake up a little bit early, but we have many children, we are staying up late because of the babies and things like this. And now the municipality found funds to bring them actually healthy food from the town. But the problem is that because it's only one certified restaurant in the city that has the approval to cook the food for them, it takes a lot of time to be brought to for the children. So it usually comes at 11 a.m. after they already ate a lot of sweets in the morning, waiting for the food. Another example was during the winter. I bring the boiling machine to the school, and I usually make tea in the morning and ask them as well, oh, do you want some tea? Do you want some tea? And it works for 1 week, maybe two. They are drinking tea every morning, but after that they just quit this habit because it's not important anymore, and they just go back to what they are. Yes.
Nonetheless, it's very nice to see local action and dedicated teachers like yourself who is acting like a negotiator between the municipality and service providers and the local community that you see is in need in better health behaviors. May I just ask the other panelists to come back as well? We only have a few more minutes, but I would like us to close. And I don't know if we still have Andrea Manzano online or if we still have Caroline and Salvatore. If not, it's very possible that they had to leave. Salvatore was on holiday today and he still joined. So we are really appreciative that he did that. And Caroline has another meeting. But Andrea, Georgiana, and Fleur, if you just have maybe one sentence to wrap up and maybe think a little bit about the responsibility of the individual, but then also maybe the responsibility of systems and institutions. So what does organizational health literacy look like? Good health literacy and good examples. And what does individual health literacy look like in your book? Just a short comment from all three of you.
I would say some exchanges of best practices among the community could be helpful for them.
That's so true. Thank you for saying that, Georgiana. And I think that some of us should, think about how we could facilitate that better. Because we do have these high and mighty meetings, especially in Brussels, and we do focus on data, very, very good. And we have very high level speakers with a lot of gravitas and very important titles. But I think the most important people are actually the members of communities and those marginalized individuals and those who have a voice to represent them. And we should bring them more to the table, and we should have proper conversations about these experiences on the ground. Andrea, you said something earlier about perceived I don't know what you said. I'm going to actually poorer self-perceived health, like obesity, smoking habits, sedentary lifestyles are less likely to participate in screening. Why is that? Is there a psychological
Yeah, exactly.
that?
I can just hypothesize because I'm really not sure. But what we've seen is that smoking and being obese is related to stigma. So many times obese patients are afraid of going to the doctor just to get the same story of you need to lose weight and your health issues are due to this. So I think that's one of the reasons, and it's the same for smokers. Perhaps that's the response they are getting from healthcare personnel as well to just stop smoking. So perhaps they are afraid of that.
Thank you so much, Andrea. And there is a comment that came in the meanwhile about out-of-pocket costs. And Eric in the comments is sharing the obvious how when vaccinations or even screening costs, that's a very, very clear barrier. But I know in one of the presentations, you've also seen hidden costs, like the transportation to go to that center, or for a family like Georgiana described, with 6 children and a baby at home and a pregnant mom, taking day off work to go to these screenings or participate in one of these campaigns is not something they can afford at all. So again,
I'm sorry, we are having with the Romanian Red Cross this program that it's called the Health Caravan, and it's going to the vulnerable places where they don't have access to screening and things like this, and they actually have free access to get all the screening and everything. And I remember 2 years ago, I'm sorry for. I went with very it was just Roma community, and there came in the morning one lady with a girl. She was 14 or maybe 13, and she was accusing for 2 weeks already very painful tummy, and she was puking in the morning, and her mother asked for an echography on her belly. And the doctor there said, maybe we should try first a pregnancy test and see after. And it came out the pregnancy test was positive. So they don't find out only after I don't know how many times they don't know anything about themselves, and they cannot go to have access to this kind of.
Thank you so much. We're near the end. I'm going to give the last word to Fleur, and then I'm just going to share with you the next webinar that we are going to be hosting, so you can all register. Fleur, any last?
So I would love to just mention one thing about personal health literacy is that in some ways I'm not convinced that it's not also organizational. So for me, a clear example is clear product labeling. So products like, I'm from the alcohol field for the last 10 years or so. So alcohol labeling, for example, the lack of clear health information on alcohol is preventing or is something that could radically change personal health literacy and I'm talking about front of packet labels, not something on a QR code that you have to know how to scan to get to. So that for the personal side. And I'd also say that what we trying to do in Peached which is really about organizational health literacy, is co-creating and co-designing interventions. And this is true both for in-person interventions and also for digital interventions, which a colleague, one of our colleagues is working on. I'll put so Gigi Erdal is working with us on e-health interventions to promote healthy lifestyles for low SES groups in Europe. So this webinar is very much in line with her work at the moment, and I'd love it if you have something you want to ask her, then you can contact her through us.
Thank you. Thank you so much. Really, really good thoughts, and really appreciate all our panelists today. You have shared so much with us, and we have learned so much from all the data that you have shared with us, the projects that are currently running, the projects that have finished and have produced some very good recommendations, and some personal insight from Georgina as well, from the community where you're active. The next webinar we will be hosting is on migration, displacement, and access to cancer care in Europe. Here's the QR code if you would like to register. It will be also in the chat box. Sorry, not chat box, in the chat. And if you would like to catch up on some of the previous webinars that we have hosted on neurodiversity and cancer, very, very specific and sort of ties in with health literacy as well, then there's a QR code for that here. There's a webinar that we hosted on LGBTQI plus cancer care. And the link is there for the video if you would like to watch it. And again, here is the registration link for the upcoming one. Thank you so much for all the wealth of information that we have learned from our panelists today. We really appreciate everyone's time. Thank you everyone for sticking with us, and we hope to see you as well very, very soon. Let's not forget about the topic that we have discussed today. If you have anything in mind, please write us, reach out to us, use social media, and keep up your advocacy so that we can see more change in Europe. Thank you so much for being with us, and see you soon.